Hi, and welcome to this snippet. We're going to be talking about position testing today. Now, this is a screening test for the lumbar and thoracic spine. It doesn't work well in the cervical spine, but in the lumbar and thoracic spine, it works extremely well. So the context is this. You've brought the patient in, you've taken their history, and you're hypothesizing this is a biomechanical dysfunction. You then complete the tests, and you then make the working diagnosis that this is a segmental dysfunction, so you're ready to start in on the biomechanical exam. This position test will make that whole biomechanical exam much more efficient and I believe more accurate. So it consists of you palpating paravertebrally for the presence of the transverse processes. Now, particularly in the thoracic spine, you may be able to just feel them in neutral, but in the lumbar spine, you can't. There's way too much overlay in it. But if the vertebra rotates when you flex or extend, if the vertebra rotates, then the transverse process is going to push against the paravertebral muscles, and you're going to feel it on that side. Now, there are a number of reasons why that may not happen, and we'll talk about them a little later, but there are some confounding issues here, but we'll come back to that. But this will give you the segment, and it will also give you in rough the movement dysfunction, whether it's a flexion or extension problem. So let's see where we go to from there. Now, if we look at flexion as a normal movement, what happens in flexion is that you bend forwards and the vertebra rocks forward, translates a little forward as the vertebral disc deforms to allow that gravity to pull it forward, and the facet joints move upwards. The superior facet moves up on the inferior facet. Now, that's fine. In that case, if you have symmetrical movement, both sides of the segment move in the same amount, then you'll pick up no change in the palpation. You won't be able to palpate transverse processes. But if, as in this case, the right facet travels further superiorly than the left, then you'll get this happening. So the vertebra will side bend left and rotate left. It will pivot around the hypo, or the lesser of the two mobile regions. This isn't coupling now, all right? We're just doing flexion in this case or extension in the next case. So it's not coupling. Coupling is when I side bend and you get a conjoined rotation with it, or you rotate and you get a conjoined side bend to it. These are obligate movements, but this isn't that. So you're getting this rotation side bending because of a pathomechanical problem. This finding needs then to be investigated with P-PIVMs and PAVMs, and this is what we'll do next. So we're going to make an example here. We're going to say that we've palpated L4 transverse processes, and in flexion, the left transverse process of L4 is posterior. Now, we can make a number of hypotheses, as you'll see as we go through this, but the first one we'll make is the easiest one to test and the most probable. That is that this is caused by a hypomobility of the left side of the segment. Now, I'm not talking about joints now, just the left side of the segment cannot flex as much as the right side. So basically, the left side lagging behind the right side, and you get this rotation set up. We test the hypothesis with a P-PIVM. We do a PA, straight PA on the transverse process, and the idea is to derotate the vertebra. Now, if it can derotate, we have a negative P-PIVM. So hypomobility isn't a factor. We move on to the second hypothesis, which is we have a right facet hypermobility. So the next thing we can do then is push on the right transverse process to see if we're getting too much movement supra-anteriorly. That is, does it reproduce pain, and or is the end field soft capsular compared to the other vertebra? Now, if we have a positive test, then we have H2 is stronger, and we can almost say it's a diagnosis. If we have a negative test, then H2 is refuted, and we move on to H3, which is either we have a compensatory problem, that is the vertebra above and below it are forcing it into this position during flexion, in which case there's no movement dysfunction, it's simply being put into that position. Or we have a congenital anomaly, and with the transverse process being deformed backwards, so that posterior transverse process is an actual posterior transverse process relative to the vertebra, not relative to space. If the P-pivum turns out to be a positive one, then we've proved H1. We can then test whether H1 is a articular or an extra-articular restriction by the PAVM. So now, instead of doing a PA on the transverse process, we push it supro-anteriorly, or in fact supro-anteriorly. So it's a glide, we're doing a glide. And as always, if the glide is positive, then the joint's involved, we have an articular restriction. If the glide is negative, then we have an extra-articular hypomobility. So this is a nice flying exam. You palpate for position, you then push on the posterior transverse process. If it's restricted, you then push it up and forwards to see if it's joint glide, and if the restriction isn't present on the P-pivum, you push the other side up to see if that side is hypermobile. It's a nice flowing issue. Now, when this doesn't work, there's a couple of occasions. One is you can't palpate the position. You have a very obese patient, and it doesn't matter. You cannot simply palpate the effect of the rotated vertebra on the paravertebral muscles. The other one is if you have a symmetrical dysfunction, that is, both joints can't flex, or both joints are flexing too much, in which case there is no asymmetry in the position, the end position of the vertebra, and you can't use this type of testing, and you have to go back to the more standard testing. But I've taught this now a few times after I've taught the standard way of doing it, flexion, extension, side bend, and rotation, and in every case I've done this, people have said to me, "Why the hell didn't you teach us that first and then worry about the other one second?" So that's what I do now. It is easier, and I think it's easier to pick up problems as well. Now, if we look at extension, it's similar, but it's a little less intuitive. So we extend, the vertebra rocks backwards, and basically there's a bit of translation backwards, and the facets now glide inferiorly. Okay, now assuming, we'll say on the right side now, that side of the segment cannot extend, the left side will, and it will result now in the vertebra rotating to the left and side bending to the left. So we end up in the same position as we did for the right-sided dysfunction, but now it's on the left and into extension. So what I can do now is say that the left side of the vertebra is extending, the right side is extending less, or not at all. And I have to prove it, and I prove it in exactly the same way, but this time I'll be pushing on the posterior transverse process again to see if that is on the left side, to see if I can bring the right transverse process down. So I'm doing a P-pivum to bring it backwards, see if it rotates, and then I can do a glide by pushing up on this side and bringing the right side down into extension. Again, if I can do that, then I haven't got an extension loss. If I can't do it, then I do. So I've got a joint problem. Now, I'm not going to do the same flow chart for you on this one. I'm going to leave that one for you to do because it's instructional and it's well worth doing. And if you haven't got a program for it, then do it by pencil and paper. But this is a very good way of sort of practicing what you're doing here. Okay, so we'll go through the basic scenarios again, but there's a couple more that I can mention here, and you can talk about a lot more when we meet. So this is all about L4. It could be any level, actually, all the way up through the thoracic spine. It works fine. So in flexion, we find that the right transverse process is posterior. Okay, so we're sitting like that, basically. And with H1 is that we have a right-sided flexion hypomobility. That is, the segment is dysfunctional. Then we do the PAVM, the P-pivum, and then the PAVM. Well, now we can talk about the facet joint being the restricted aspect of it. So that's H1. H2 is that the right joint is hypermobile. We go there when the P pivum is negative. And then we actually basically push on the right side to see if it does glide up too much. So again, not that you're going to feel the extra movement, but you'll feel either the soft capsular end feel, or you'll produce pain when you do it. And pain at the end of a normal range of motion denotes hypermobility. H3 is this is a compensatory position from other vertebrae, or it's an anomaly. Second scenario is in extension, the left transverse process is posterior. So we've got this happening here, if I can get my directions right. So the posterior transverse process here, the first hypothesis is that we have a right side extension hypermobility of the segment. And again, we test that with P pivot terms. Second one, when that doesn't work out, is that the left joint is hypermobile into extension, and H3 is a compensation or anomaly. Now, it is possible to have the inflection, the right transverse process posterior, and in extension, the left transverse process is posterior. And what you're saying is that the same joint is hypomobile in both directions. It's a flexion hypermobility and an extension hypermobility. And if the joint glide is positive, all right, now this is an arthropathy. It's either a fibrosis or an arthrosis with a capsular thickenings. So that denotes a right joint arthropathy, but it's got to be associated with a positive pavum. In flexion, the right transverse process is posterior, and in extension, the right transverse process is posterior. This is either both joints, one of which can't flex and the other one can't extend, which is certainly unusual. Or, more usually, this thing is subluxed into rotation. In this case, it would be into right rotation to bring that right transverse process backwards. Now, a right rotation subluxation is exactly the same as a translational subluxation, so it's gone sideways. They're the same thing. How you name them really depends on what you're going to do to them. Now, the direction of the translation can't be deduced from the rotation. Regardless of what your feelings are about coupling, this is a very dysfunctional segment and there's no reason to expect it to follow along that. So what you do is you translate it and you find out which translation it can't do. And it's subluxed in the other direction, basically. So, and the reason you can, well, it's not a reason why it is both, it simply is both. But if you want to term it a rotational subluxation, you can manipulate it with rotation. If you want to term it as a translational manipulation, subluxation, you can glide it or manipulate it as such. Now, H2 really doesn't exist for this. I can't think of one. But again, H3, which would then be H2, of course, it's an anomaly. That is, you really do have. In which case, the deformed transverse process should also be present in neutral. Okay, so this is a fairly straightforward process. The thinking behind it is fairly straightforward. You just have to get used to doing it. Okay, that's it. I mean, this is an extremely useful tool. It's much better than doing the flexion, extension, side bending, rotation, which can be really difficult to feel. It's a position that leads you into a series of hypotheses that you can prove or refute with proper testing. Okay, so I hope this helps, and we'll talk about it when you need to. Okay, bye guys.